My name is Manuel Miron. I'm the head of the Hospital at Home services at Hospital Universitario de Torrejón, Madrid, Spain. In addition, currently also the president of the Hospital at Home Society in Spain. I'm an internal medicine specialist, and I've been working as a doctor in the hospital at home field for the last 20 years. Hospital at Home provides care at home with hospital resources that include human, material, but also organizational resources. The main objective is substitute the hospital bed for the patient's bed at his or her home. Therefore, if the hospital at home doesn't exist, the patient should remain admitted. For this approach, we use the term home hospitalizations or acute hospital at home. But last years, we've realized that some patients need care at a hospital level, but not necessarily a hospital bed, even in a hospital at home service doesn't exist. For example, for treating oncohematological diseases with cytostatic drugs, performing blood transfusion, infuse some drugs, usually infused at the hospital for patients with chronic conditions and deteriorate functional status, etc. In that cases, we use the wider term of hospital at home. So therefore, the most used words in our country, society, are home hospitalization and hospital at home. I started working in the hospital at home model of care in 2002, first as an assistant physician when I finished my specialty at the Hospital Joan 23 de Tarragona, Catalonia. They offered me that position in a moment when the hospital was overcrowded, so the beginnings for me were not relaxed. And in 2011, I started working in a new hospital as the head of the service in the city of Torrejón de Ardoz, near Madrid. We start with a planning session, nurses and doctors all together. In that session, we review the needs of each patient and what we have to do for each of them that day. Then we plan the visit route. Sometimes doctors and nurses visit patients together, sometimes don't. It depends on the patient's needs and features. Then doctors go back to the hospital first, assess the hospital at home proposals, and make administrative tasks. At the end of the morning, nurses go back to the hospital as well and assess these new patients. In the afternoons, doctors are on call and there is an on-person nursing shift. At weekends, doctors are also on call and nurses visit patients both mornings and afternoons. And at nights, we have nurses on call. And what motivates me, the most important thing, and the reason why I keep on this model of care is to be in contact with the patients, relatives, caregivers in their homes, and have the feeling of how beneficial it is for them. It's like going back to a traditional way of doing medicine, and that is enriching for us as professionals. First obstacle, I think, is financial obstacle. Hospital at home is cheaper than traditional admissions, but even so, hospital at home needs to be financed. So this is, I think, this is a politician topic. Another barrier is the government support. We need this support and regulation rules in order to spread this model of care through the country, through the nations. We need also professional motivation is another barrier. We need new professionals dedicating their careers to care patients at home from a hospital approach. And in that sense, we have to drive training activities and be able, this new professional, to experience the benefits of this model for the patients and for themselves. And I would say another barrier or obstacle is the coordination between stakeholders. We need to improve the coordination circuits between all actors and stakeholders, and also in the private sector between the clinicians and the providers. Well, I think hospital at home is different from home care related, linking to or depending on primary care, are completely different. Hospital at home is not home care service for patients with social needs. It's not a service for follow-up patients with chronic conditions. And it's not a service for caring all kinds of palliative patients. Hospital at home should care only palliative patients with acute needs, like in the hospitals. I will have people and professionals to know that hospital at home is good for patients' healing process, or for them to be more comfortable when there is no healing option. Is cost effective. It's not only cheaper, but also useful for more effective way of managing resources. And it's also a great opportunity for some professionals frustrated with the way that the medicine provides solution for some patients nowadays. I'm talking about all disabled, vulnerable, chronic patients. I think it's a nice opportunity for networking. We need to share our experiences, what is different and what is similar about our models of hospital at home. And we can know that by being in contact with professionals from around the world. It reminds me the process we have experienced in the CEHAT, in the Spanish Hospital at Home Society, first sharing experiences among hospital at home members and professionals, and then spreading our model of care to other health professionals and stakeholders. I'll be very happy if we are able to reach a consensus about hospital at home definition, and or if we are able of finding criteria for classifying the hospital at home activity. And it will be also great if we start working on establish a skill map for hospital at home professionals.